So thank you very much for coming to today's BESC lecture. We will start our lecture with Dr. Ionita's presentation on the challenges of triage. Triage, what I mean is from the moment EMS team drops off the patient through the, carries the patient across the hospital door, to the moment the patient leaves to CAT scan. CAT scan and imaging will be the topic of your next meeting in May. This month we are talking about the triage.
Good afternoon, everybody. So I'm going to try to be brief and to the object. And every single person is technically in the trenches battling stroke, no matter from what position: interventional neurology, interventional radiology, stroke neurologists, neurointensivists such as myself. We are all aware of the challenges that we have to face. So,
You switch.
I switch?
You switch
Okay.
to the right. Or down.
Okay.
Yeah, good.
So the greatest challenge of all, there is compelling evidence that stroke treatment is a really time-sensitive matter. So the biggest challenging, and that's happening based on a national initiative, is shortening the door-to-needle and door-to-groin times. That implies early diagnosis and treatment of the acute ischemic stroke, no matter what that is. And because the good times of the old type neurologist taking his time to do his diagnosis and not really treating too much is gone, now we're facing a paradigm shift. Technically, we kind of shoot first and then we ask. So obviously, that raised some concerns of safety of thrombolysis in potential stroke mimics. But technically, the greatest concern we should all have is not to miss strokes in disguise, because the reversal situation is perfectly possible. There's strokes that they are disguised in a different condition and can be easily missed. Technically, stroke diagnosis is a clinical diagnosis supported by an abnormality on the brain imaging. Unfortunately, that's not always the case. And by definition, a stroke is a focal neurological deficit secondary to a vascular abnormality. Current practice is, in order to shorten the door-to-needle and door-to-groin time, what we do, we take a brief history, we do a even briefer clinical evaluation, technically an NIH stroke scale score, run the patient in a non-contrasted CT, and if there is no hemorrhage of any sort or type on that CT, based on the current guidelines, just based on the suspicion of stroke, we administer the TPA, and me personally, I activate the endovascular team when I have high suspicion of large vessel occlusion. Additional imaging, CT angiogram or CT perfusion to identify a large vessel occlusion and eligibility for endovascular therapy might happen or might not. It's a lot of institutional variability. And many times when we see a dense MCA sign or we have a quite high certainty that we're dealing with a large vessel occlusion, we might not, and the patient is within the time window, we might even skip the CT perfusion CT angiogram. To rule out intracerebral hemorrhage and subarachnoid hemorrhage based on a plain CT, it's a relatively simple thing to do. But due to the time constraint, other conditions than acute ischemic stroke presenting with focal signs, focal neurological deficit, otherwise stroke mimics, end up being treated with intravenous TPA at the least. And that is happening in about 7% to 31% of the situation. And on the other side, a good proportion of patients treated with IV TPA in the emergency room will end up having a negative neuroimaging for cerebral ischemia at 24 or 48 hours post-treatment. And there are multiple possibilities of that, why that is happening. It's very possible that we just TPA a TIA, we TPA the stroke mimic, or the patient achieved with the TPA such a rapid recanalization in a context of hypoperfusion above the ischemic threshold to the point that he does not develop a stroke visible on the imaging. However, in the world of the neurologists, there is a lot of concern for the, that we might administer a potentially dangerous treatment targeting a condition that the patient doesn't have, and we just expose the patient to an unnecessary risk. So let's see what are the most common stroke mimics. By far, seizures are the ones, sepsis, toxic metabolic situations, and I'm referring primarily to hypoglycemia, hyperglycemia, tumors, syncope, presyncope, acute mononeuropathy. It happened to me a couple of times to TPA a Bell's palsy, I must admit, or a radial mononeuropathy, dementia, migraine, but by far in my institution the most common stroke mimic is conversion disorder. And there are other studies that are listing this as a high occurrence in the emergency room. And then complicated migraine and seizures. There are factors predicting stroke versus mimic that can be quickly analyzed even at the level of the emergency room level. And it was a study looking at a univariate analysis involving multiple patients with stroke mimics treated with IVTPA. Odd ratios are higher than 1 predicted stroke, odd ratios less than 1 predicted mimic of stroke. And when you look at a past medical history, if the patient has history of ischemic heart disease or peripheral vascular disease, the probability of having stroke is higher. But if the patient is known having cognitive impairment, it's a high probability you're dealing with a stroke mimic. Presenting complaint, it's also important, and the presence or absence of the exact time of onset. When the patient knows precisely when his deficit started and he has a deficit focal sign, the probability that this is a real stroke is quite high, whereas when the patient had loss of consciousness, headache, seizure at the onset, and lack of lateralizing signs, it's more likely that we are dealing with a stroke mimic. Looking even at the general examination, vitals that we all check before we treat stroke, a systolic over 150, diastolic over 90 are highly predictive for stroke, whereas abnormalities of other systems or confusion are predicting mimics. And another important feature is by your quick evaluation, you are able not only to smell the stroke, but to be able to kind of categorize the stroke. Like the patient has a left MCA syndrome, or posterior circulation, or PCA syndrome, or something like that. The probability that you are dealing with a real stroke is higher than dealing with a mimic. The NIH is also highly predictive. And as you can see on that picture, as NIH is going up, the probability that you are dealing with a real stroke goes up also. When there is a low NIH, it's kind of hard to decide that you're dealing with a stroke or a stroke mimic. But at the end of the day, does it really matter? Does sensitivity of diagnosis in such a short period of time, it really matters if you're dealing with a stroke or a mimic? And the big question is intravenous thrombolysis safe? So we all know the most feared complications of intravenous thrombolysis is intracerebral hemorrhage and sometimes orolingual angioedema. By searching the literature, I found 3 single-center data and also a meta-analysis based on 9 studies that they were available. A first study, 106 patients with stroke mimics treated with IV TPA. Out of 512 patients treated, they reported symptomatic intracerebral hemorrhage 0 and angioedema 0. So none of the stroke mimics treated with IV TPA bled. On the other side, looking at the patients who had a real stroke and got IV TPA, the rate of bleed was 5.8% and angioedema 2.2%. Other study looking at 100 patients with stroke mimics, out of more than 5,000 patients treated with IV TPA, reported a rate of symptomatic intracerebral hemorrhage post-TPA of 1% in the stroke mimics group and 7.9% in the stroke patients group. And last but not least, another study, 75 patients with stroke mimics out of 516 treated with IV TPA, reported 1% rate of symptomatic intracerebral hemorrhage and 0 angioedema. While in the real stroke patients group, it was a rate of bleed of 5%, but also no angioedema. Pooled data coming from 9 studies looking at patients with stroke mimics treated with IV TPA, putting together 392 patients with stroke mimics, reported a 0.5% rate of bleed after IV TPA. And looking at the orolingual edema, 0.3% rate. And looking at a favorable functional outcome, 84.5% patients had an excellent outcome after IV TPA. So it's not only that it's safe to TPA stroke mimics, but apparently it works. It works as a charm. And looking at the forest plot of the favorable functional outcome defined as a modified ranking scale 0 to 1 at discharge and 3 months of stroke mimics and acute ischemic strokes, treatment with IV TPA actually favored the stroke mimics. In conclusion, when you see a patient in ED that doesn't have an exact time of onset, doesn't have focal signs, has seizures at the onset, cognitive impairment, lack of vascular risk factors, traditional ones, altered consciousness, and low NI stroke scale score, these are factors predicting rather a mimic than a stroke. But when the patient can't point at exact time of onset, he's got focal signs, he's got high NIH score, he's got the traditional risk factor for stroke, and you can be sure you're going to find some vascular abnormality on the brain imaging, and that's highly predicting for acute ischemic stroke. So the conclusion is that IV TPA is safe in patients with stroke mimic and unlikely to lead to terrible complications as long as we stick with the protocol and we avoid the contraindication. On the other side, there is the stroke in disguise, which I think it's a lot more dangerous than TPAing a stroke mimic. And in my experience, failure to diagnose stroke in the emergency room is the most important reason for delays in door-to-needle and door-to-groin time. And recent studies have proved that about 20% of acute ischemic strokes are missed in the emergency rooms in academic centers and about 26% in community hospitals. And interestingly enough, 35% of the missed strokes were seen by neurologists. 33% of the missed cases presented within 0 to 3 hour window missing the IV TPA opportunity, and about 11% within 3 to 6 hours missing the endovascular intervention opportunity. And it all starts with the triage, because only 8% of the missed strokes were triaged as stroke alerts, stroke codes, and 46% of correctly diagnosed strokes were triaged appropriately. So the index of suspicion should not be only at the ED level, ED physician, neurologist, or whoever is first assessing the patient, but also the EMS should have a high index of suspicion for stroke. And what are the symptoms that the patient presents and are usually associated with missed stroke diagnosis in the emergency room. Usually lethargy, disorientation, dysmetria is very commonly missed, headache, nausea, vomiting, while the patient is presenting with gaze preference, focal weakness, focal numbness, aphasia, meaning again strongly localizing signs, the probability that the stroke will be missed is quite low. Although in the real life, anterior circulation strokes are more common than posterior circulation strokes, 70% versus 30%, more posterior circulation strokes are being missed than anterior circulation, 37% versus 16%. And there are other studies suggesting that posterior circulation strokes are 3 times more likely to be missed than anterior circulation strokes. NIH stroke scale score is skewed toward anterior circulation strokes related deficits. Therefore, missed stroke have usually a low NIH. And now I just kind of present just a couple of cases from my experience. 36-year-old woman with known seizure disorder related to perinatal stroke. Presents to the emergency room unresponsive, actually en route to the hospital. She had witnessed seizure by the EMS. Last seen normal 3 hours before. She was right gazing. She had no blink to thread bilaterally, and she had only trace of movement in all 4 limbs. NIH stroke score quite high, 23. And she was supposed to be on Keppra, but she was notoriously non-compliant. This is the way the CT scan looked like. So what do you think? Is this a stroke? Is this a mimic? Who would TPA? Who would take to the cath lab? Her NIH is 23. What do you think? She's got this large old stroke, perinatal stroke, known having seizure, right gazing. So probably, you wouldn't TPA, right? You would give her Keppra, right?
I would probably still do a TPA because she's weak in all 4.
Well, because I'm not interventionalist, I did a CT perfusion. A little voice came and whispered into my ear, perfuse her, do perfusion, do perfusion. Why is she right gazing? I get it, she's post-ictal, but why she's not moving to the left? Why is she right gazing so badly? And this was the surprise. Well, I gave her Keppra in the CAT scan. I TPA'd her. She was taken to the cath lab perfectly open. She recanalized with the TPA because probably it was like just an M2, and TPA worked. It turned out she had a PFO. She's been discharged 2 days later, fully recovered. So this is a mimic of a mimic, you know, something like that. 35-year-old black man, college student, family man, father of a 2-year-old, working full-time, playing basketball. He collapsed on the basketball court, and he was brought to the emergency room completely unresponsive, completely non-focal, risk factors for stroke absent. Within 30 minutes, he actually arrived in the emergency room. His head CT, you gotta believe me, was perfectly normal, and he was non-focal. It was a urine drug test run that was perfectly negative. About 140 minutes after his arrival, the patient starts to become focal, to develop focal signs. He's perking up, waking up, and he displays right-sided weakness, and he cannot talk. Then a stroke alert has been called. He received IV TPA within 155 minutes after arrival. Successful recanalization in the cath lab was achieved in 244 minutes post-arrival, unfortunately. That's a great example of a delay of misdiagnosis. Patient arrived as altered mental status and not a stroke. He was not triaged initially as a stroke, and unfortunately this was his final result. The diffusion-weighted imaging showed quite a bit of infarcts in spite of successful recanalization in the cath lab, and TEE showed a PFO. And that would be all I have to tell you for now. Questions? We cannot all talk about success only. So we have to talk about pitfalls as well. No question. Okay.
Thank you. So wait, when you ask, please talk in the microphone. Give me the other mic, so that we can actually.
So, would you be able to elaborate on the protocol that you have at Holy Cross for patients arriving in the hospital in terms of when patients get what kind of imaging, non-contrast CT, CTA, possibly CT perfusion and MRI?
Excellent question. So let me tell you a little secret. About 3-4 years ago, I wouldn't conceive giving IV TPA to a patient without having a documented stroke. CT perfusion, CTA on top of plain CT to rule out hemorrhage. The protocol is very simple. The patient arrives, gets his quick evaluation, NIH history, exclusion criteria, that some of them, they overlap with endovascular as well. You might be nervous to intervene in someone who's on Xarelto, let's say. I'm just giving an example, or platelets 50,000. And then the patient goes to the CAT scan. I usually go with the patient in the CAT scan. If the CAT scan is negative, I shoot the TPA, period. And then, if my colleague is not in-house, I always notify him, particularly when I text him, hi NIH, so-and-so. The patient gets perfusion and CTA, and he will choose to intervene or not intervene.
Now, let me add that we do have a protocol that at Holy Cross that all patients, or with some exceptions, all patients get
all of
CT
them,
perfusion.
CT perfusion, CTA, yeah.
And then as soon as the images are up on PACS, I get a text from the CT tech that pictures are up, take a look. So middle of the night, doesn't matter, I take a look. And then I report it to either the emergency room physician or Dr. Ionita if I know that she's on the case.
And in my case, in the middle of the night also, obviously I can't be in-house 24/7, 365, but I make my decision based on CT from home. I give okay for the TPA, jump into my car, drive right there, and I meet with Laszlo. If I get them before him, I get even the consent for him.
And I have to add that, as you know, CT perfusion has kind of no influence on giving IV TPA. It
No.
should not. CT perfusion is a decision-making for intervention.
Although, to be honest with you, I had patients in Buffalo I TPA'd based on CT perfusion with unknown time of onset.
I remember one case recently where
And consent. I get consent.
where we were suspicious that it's not really a stroke. And then the CT perfusion showed that, oh, that patient does have a stroke, so then we gave TPA.
But if the NIH is 0, as you can imagine, I'm not going to treat CT perfusion. I still treat patients. So, because it appears to me that there is a lag on the CT perfusion abnormality. Even if the patient improves, the CT perfusion abnormality might persist. So I do not treat scans. I treat patients.